Welcome, everybody. Happy Monday morning. It is my pleasure to present our speaker this morning, Sid Srivastava, who has been with us for the past almost 3 months now. He's one of our BNI residents. He did his undergrad training at University of Texas in Dallas, and then did medical school at Johns Hopkins. And thank you for your work on our service, Sid. It's been a real pleasure spending time with you. And I know this is one of your areas of interest, so we look forward to your speaking. Thanks.
Thank you, Dr. Bristol. Thank you, everyone, for attending my grand rounds this morning. So, as Dr. Bristol had mentioned, I'm Siddhartha Srivastava. I'm a PGY3 at the BNI. I am, as you can see, interested in spine. I will be pursuing a fellowship with Dr. Jay Turner in my PGY6 year. Um, and the reason why I chose this topic to present this morning is that a lot of the work in adult spinal deformity actually came from the work done in the pediatrics world. Pediatric spinal deformity is where a lot of this research started, and now we just kind of build on a lot of the principles that we learned along the way. The other reason is that when I first started my residency, I would come into spine rounds and I'd usually see photos looking something like this. I imagine this is also a lot of hieroglyphics to most people in the audience, and really it delves on the spinal pelvic parameters and angles that we use to try and assess exactly what type of treatment we're going to do. But without a fundamental understanding of what's going on, it really just looks like random lines that we drew on an X-ray. But I wanted to kind of learn a little bit more about the history of where this came from in the form of pediatric spinal deformity, and that's what I delved into. And just as a quick, interesting plug, I was a huge math and science nerd growing up, and it always was remarkable to me that this theory of relativity, I'd read it in high school, and this fundamental theory that kind of challenged our entire understanding of the universe and our place in it was able to be written in such a succinct and concise manner, such as a high school student could even understand it. And I personally have always believed that if you are unable to explain something simply and you just kind of expect someone to know what this is off the top of their head without really knowing how to explain it well, then it just means that we don't understand it well enough. So I hope to kind of shine some light on these angles and also our approaches and treatments to spine deformity in the pediatric world. So the main objectives for today, if there was only three things that I would hope to impart upon our audience, it would be number one, the spine is a dynamic organ. What I mean by this is that often we get an X-ray, we get a CT scan, and it just looks like we have a snapshot in time. Is this something we need to operate on? What do we do here? But in reality, to properly treat spinal deformity, it's something that's watched over time. There's growth plates at the end of every vertebra. There's osteoclastic and osteoblastic processes that are constantly, in flux. And on top of that, there's Wolff's law. So the forces that are applied to the spine really help inform our approach to deformity. The second part is that there's still many approaches and lack of standardization even today. So something we say often is that, you could go down the street and whereas one spine surgeon might be recommending a minimally invasive approach, the other spine surgeon might be instead recommend a very maximal open approach to the same pathology. So there's really a lack of standardization, and a lot of the classification systems that I go through today and approaches are an attempt at trying to standardize it. And the third thing, when I discuss the complications of treatment for pediatric spinal deformity and also approaches. It's to remind myself really that neurosurgeons are doctors first and foremost and have to have a holistic approach. So it sometimes we look at this scan and we can say, oh, there's a deformity, there's a fracture, there's some pathology there. It's got to be fixed. Ultimately, though, we have to look at the patient as a whole. There's spine surgery interacts with the rest of the organs as well. And as I'll get into, there's a lot of these deformities can be adjacent to other syndromes that involve other organ systems. So we don't exist in silos. It's a team approach. And it's just always a good reminder. So with that being said, we start with the classification of pediatric deformities. So the one that if you, most of our members in the audience will hear most often is going to be idiopathic scoliosis, and that's mainly because it's the most common form. But just as a 5,000-foot view, there are lots of other forms as well. So they can be secondary to neuromuscular disorders. This is how I was getting into earlier, that the spine is constantly subject to biomechanical forces, and if you have a neuromuscular syndrome, then the spine is going to be affected by um, the aspects of that syndrome. As well, there can also be congenital spinal anomalies. This can involve failure of formation or segmentation of different aspects of the spine. And so all of this, it's not just about scoliosis, although I just wanted to emphasize that idiopathic scoliosis can be the one I focus on today. For the large part, it's probably going to be the one you will see most in your practice. So in terms of classification, this is just to show that, we're not just looking at a curve and saying, oh, that's scoliosis. There's objective definitions. And the definition is a coronal plane. So when you take an AP X-ray or a coronal CT, deviation of greater than 10 degrees. So a lot of radiographic tools now allow you to draw a straight line from the end plates, and it'll calculate this angle for you called a Cobb angle. And as long as that's greater than 10 degrees, it's now considered a scoliosis. The original classification was an age-based criteria. So if you're less than 3 versus 3 to 9 years old versus greater than 10, that's how it was originally described. And honestly, many papers today still kind of use this criteria, especially when we say AIS, that's short for adolescent idiopathic scoliosis. But nowadays, we recognize that the juvenile form is pretty rare. And the growth velocity itself is pretty constant during these years. So really, people have started to think of it as, is it early onset, which means it's less than 5 years old, or is it late onset? So between 5 and skeletal maturity. The rate of growth of the spine is particularly rapid during these early years. So that's really what we care about. I wanted to emphasize that the field of spine surgery in general is a relatively novel field. So it would this classification was one of the first and real great attempts at standardization in the attempt of approach to pediatric spinal deformity. And it was only developed in 1983, which is quite uh, recent, actually. In fact, as I was looking into the literature, the first spinal laminectomy, which is one of our more simpler spine procedures today, was done in the mid 1800s. And the person who did it was actually stated to be a heretic because no one believed that you could operate on the spine and someone who was not very mobile before was able to walk 6 weeks later. So, just in general, this is a constant and evolving field. And this King Mo classification was the first time someone had tried to actually standardize this treatment so that a spine surgeon across continents, across states, would be able to assess the same radiograph and come up with treatment approaches. So the curves are divided in this classification into 5 types. Um, and the recommendation for what surgery use is dependent on the curve type. But the real benefit of this classification system is it started to define these terms that are still used in the newer classification systems today. So the first one is stable vertebra, and this is the vertebra that's most closely bisected by the CSVL. Now, I'll get more into what the CSVL means. It's a central sacral vertical line. I'll explain in the coming slides exactly how to draw that. But basically, if you draw this line, as you can see on every single one of these, 1 through 5, it's that line going up and down. It's the vertebra that is most closely bisected by that line. Those are considered stable vertebra. And then the other term that was very useful is the structural versus a compensatory curve, which once again, I'll define in more depth on a coming slide, but these are terms that you're going to hear throughout um, anyone who operates on pediatric spine deformities, and this is where they come from. Um, the main reason why this was helpful is because it allowed for a singular t treatment approach. And so there are these old spinal constructs called Harrington rods that now we don't really use anymore. But based on which curve type the patient was, it would be instrumental in telling you which type of I'm sorry, which levels of Harrington rods to try and fuse the patient as the first attempt at standardization. The issue is that there was low inter and intra-observer reliability for this kind of classification system. So that's not great when you're trying to standardize approaches. A second shortcoming was that this didn't really look at the sagittal plane, only the coronal on AP X-rays. So that's when the Lenke system was created, and this was to address the limitations of the King Mo system. Once again, 2001, pretty recent. This is largely the classification system most providers use today, but um, this is a constant evolving field. Uh, the benefits of this one compared to the prior system was that now they also involve the sagittal and coronal planes. And, I remember seeing a chart like this once again. Um, it still seemed largely Greek to me. Uh, everyone says, oh, you just look at the chart and you'll get the system. It's pretty straightforward. But I'll kind of try and parse the hieroglyphics a little here. So the apical vertebra is important for before you can classify what level of spine or what type of scoliosis this is. That's the farthest level away from the central sacral vertical line. So the CSVL, I'll show you how to draw that. But the vertebra that's farthest away from that line, that's the apical vertebra as part of the curve. There's 6 curve types that you can see, type 1 through 6. Once you categorize the curve type, that's the majority of using this chart. Um, to categorize what kind of curve type it is, you have to know that there's 3 curves on the spine. There's the thoracolumbar curve, which goes down to about T12. There's the main thoracic curve, which is down to about T11. So, and then the proximal thoracic curve, which is starts from around T3 to 5. So those are the 3 fundamental regions of the spine. In order for there to even be a curve, it has to be 25 degrees. And then there's lumbar and sagittal modifiers. The lumbar is more common. Not too many people look at the sagittal. So this is what the CSVL is. It's where you draw a line that connects the top 2 iliac crests. That's because the pelvis can be rotated as well. So we want to make sure that this is a flat line. Here, the pelvis isn't rotated, so the CSVL is just going to be a straight line going left to right. And then the actual CSVL is a line that's perpendicular to that iliac crest line that perfectly bisects the sacrum. So if you look at this, that one line that says CSVL, it's going right in the middle of the sacrum, and it's perfectly perpendicular to the line connecting the top of the iliac crest. The next important rule for the Lenke criteria is that the curve has to be at least 25 degrees to even be considered a curve. And the second part is that the curve must not be able to reduce to less than 25 degrees on a lateral bending film. So this is where you put a bump to try and get the curve to reduce. If the curve reduces to less than 25 degrees, then it's a non-structural curve. If it doesn't reduce, then it's a structural curve. So for example, here's a patient who has a 61-degree curve of scoliosis. If you can see on the X-ray film on the right, there's now a bump on the patient's right side that causes the curve to become 31 degrees. However, it's still greater than 25, so we would call this a structural thoracic curve. How do we know which levels to include in our curve angle? It's the levels that are all pointed in the same direction. So I drew in these red lines. As you can see, if you draw these red lines on the vertebral end plates, you see the one that's pointing to the left would not be part of the curve. So T11 doesn't make it into this patient's curve. But the red lines on T12 to L1, and then if I were to continue L1, L2, L2, L3, if I drew lines from each of those end plates, they'd all point towards the same side. So all of those are part of the curve, and that's how I measure the angle between those vertebrae. Um, and once again, I just want to point out when I had mentioned apical vertebra, in this example, that would be L2, because that's the vertebra that's furthest away from this CSVL, that central line going down the middle. So if you look at the original chart, if the curve types dependent on whether those curves are structural and whether they're major or minor curves. So how do we know if something's a major or a minor curve? The major curve is simply the curve on the patient that has the largest angle. And the only rule is that the major curve has to be structural, so it cannot reduce to less than 25 degrees. All the other curves on the patient are considered minor curves. So in this example, we have two curves here. Um, it's going to be the thoracic curve and a thoracolumbar curve. The main thoracic curve is 30 degrees. If we assume that this curve does not reduce to less than 25, then we would say that this curve is a structural 30-degree main thoracic curve. Similarly, the thoracolumbar curve is 43 degrees, but because it's bigger than the 30-degree curve, this would be called the major curve. Just from clinical guidelines and practices, a stiff curve is the one are ones that don't reduce that much. So if a 43-degree curve from the last one only became 40 degrees on lateral bending, that would be a stiff curve. Those are just in general harder to treat, often need bigger surgeries. So finally, I'll just discuss the lumbar spine modifier. That's also part of the Lenke criteria. It's pretty straightforward. You draw the CSVL, the line that bisects the sacrum, and then you look at the lumbar apical vertebra. So that's the lumbar vertebra furthest away from the line. And you look at, does the line go in between the two pedicles? Does it touch one of the pedicles? Or is it completely medial to both of the pedicles? And that tells you what type of modifier that spine gets. So, for a final example, if we were to classify this patient, we would say that let's assume both curves are structural. So we'd start with, we have a 45-degree curve and a 40-degree curve. So the major one is going to be the main thoracic curve because it's larger than the thoracolumbar. So you're going to have a 40-degree major structural curve. And let's say and so that means it can only be a type 1 through 4 because type 5 and 6 do not have a major structural curve, main thoracic curve. Um, then the next step would be is the thoracolumbar curve structural or non-structural? Let's assume in this case it is structural. So that means it can only be a type 3 or a type 4. And if we take a look, what's the difference between type 3 and type 4? There's a proximal thoracic structural curve. This patient does not have a proximal thoracic curve, so then we would say that this is a non-structural proximal thoracic and it must be a type 3. So we would call this a Lenke 3. And then if we add the lumbar spine modifier from the last slide, we can see that every single lumbar vertebra is has their pedicles straddling this line. So the CSVL goes in between the pedicles. That would mean it's a lumbar spine modifier of A. So if I were to tell another surgeon about this scoliotic curve, I would say this is a type 3A. The main reason I just kind of went through this whole classification criteria is just to show that there is a way to classify and standardize these curve types so that once again, a surgeon in one state talking to a surgeon in another state or even down the road can say, hey, I have a patient with a Lenke type 3A. This is the surgery I was planning on doing so that we can begin to standardize treatment approaches. And this is just, once again, another chart showing that you should be able to kind of visualize the curve as long as you know the curve type. So what are the pros and cons of this system? It was created to have a better inter-observer reliability compared to, in the 90% range compared to a 64% on average in the King system. But obviously, not everything's perfect. Further studies have sometimes showed a reliability as low as 56%. So this isn't the end all be all. And I've seen spine surgeons treat the same curve type with different approaches even now. So it's still an evolving field. Uh, it is more objective and complete than the King system. It does account for the three planes. And the most important aspect of the Lenke system is, like I had mentioned before, the King Mo system was great for the Harrington rod, but now with the development of segmental fusion, which just means that we can decide individual vertebral levels that we decide to fuse. The Lenke system really took over because it can guide us on exactly which levels need to be fused. Um, so they actually have done studies that show that people who use the Lenke system to decide what levels to fuse, those patients have better outcomes. And the most important aspect of it is you got to watch out for both ends of the spectrum. You don't want to fuse more than you have to. And so everyone's very keen on trying to fuse the least amount. But there's also a downside that you don't want to undercorrect because the spinal deformity will progress or get worse if you don't fuse enough levels. And the Lenke system really kind of hits that sweet spot. The downsides are the complexity, as much as any spine surgeon would love to tell you that, they have every single Lenke curve completely memorized. And while I'm sure many of them might, there's still reference cards everywhere. We generally do have to reference the system to see what exactly type of curve we're looking at. And the other downside is that it still really only has two modifiers. And with evolving surgery, we're realizing that, the spine is really a 3D system. So now let's get into the different types of deformities. The neuromuscular deformities, as I mentioned before, this is secondary to abnormal muscular control of the trunk. And like I had mentioned, the spine is a constantly dynamic organism. I'm going to keep hammering that. So if the muscles do not embryologically form as expected, then you can expect the spine to also have some sort of deformity. So there's different types, flaccid, spastic, there's dystonias, and there's a difference between a developmental and acquired neuromuscular deformity that are beyond the scope of this talk, but I just kind of wanted to emphasize that the spine will be a part of neuromuscular syndromes. There's also congenital spine anomalies, and here are some examples on this figure on the right. But these are really just failures of embryologic development. So these are particularly difficult to treat because the growth plates at the end of these vertebrae can be fully intact. And so these can be unilateral, bilateral. It can cause congenital fusion across multiple levels. And so, for example, if you have a hemivertebra at one level, but the rest of the spine has normal growth plates, you will get a deformity because the spine is expecting to grow what it thinks is an up and down pattern. But if you have this wedge deformity, up and down is now relative and it's going to start going on a coronal deviation. So these are particularly hard to treat. So how do we approach patients in who have, pediatric spinal deformity? And it really starts with the clinic, whether it's in the ED or, an outpatient evaluation. It's going to start with history taking. So there's a lot of important factors here, birth and development. Has there been any cognitive or motor challenges? Is this part of a global syndrome? And once the changes over time is really key. So I wrote signs and symptoms, but really changes over time. We get multiple repeat imaging months to years apart, and what has changed in the patient. Pain is not pain. So quality, intensity, location, change, radiculopathy, these are all things that we care about. And ultimately, what really matters is the holistic care, and that comes with quality of living. So yes, a patient might have a deformity, but how much does it disrupt their life? Is there a chance that if the deformity stays stable, the patient would not want any surgery because they're not having any symptoms right now? And once again, patients with a syndrome can have many different organ system involvements, and this is something that the neurosurgeon has to be aware of so that we can refer to the appropriate teams so that patients get their holistic care. Physical exam is very important. This also clues us into possible syndromes. If there's cafe au lait spots, freckling, midline dimpling, um, we like to evaluate gait. Like I mentioned with the X-rays, there's lateral bending to see if the curves are flexible, and of course a general exam, motor strength, sensation, tone, reflexes, bowel bladder, and an important one is also taking a look at limb length discrepancy. The spine, well, it is a organ to be looked at as a whole. It needs to be evaluated with the entire skeletal system in mind. So, it's connected to the hip, it's connected to the limbs, and a limb length discrepancy can be the reason for a spinal deformity as well. Imaging, X-ray is going to be our cornerstone, AP and laterals. This is how we use this is what we now use for the global assessment of the spine, especially in the adult world now too. We're realizing that, the alignment of even the head, and the hips, and like I said, the limb lengths, they're all need to be assessed together. So all those angles that I showed in the first slide, um, that's how we start with looking with an X-ray. And then CTs as well. Nowadays, these are becoming more common, less so in the pediatric population to prevent radiation exposure, but nowadays it's very helpful to look at, what the pedicles look like for operative planning, and especially for things like congenital deformities, hemivertebra. Those are still very hard to truly evaluate on X-rays. CTs are very useful in that to help us out. Do we get MRIs? Not all the time. MRIs are useful though for intraspinal abnormalities. So, for example, if you know you have a patient with a congenital deformity, there's a prevalence of about 15 to 38% of some sort of intraspinal abnormality in these patients. So, it's a good idea to have an MRI on board. So, it's not necessary for every patient, but for things, if you want to evaluate for tethered cord, a syrinx, tumors, anything else, MRIs can be very helpful. And it's really useful for any patient who doesn't fall under the typical mold of, just standard, straightforward scoliosis. So if they have neurologic abnormalities, if they have very large curves on their spine or rapid progression, these are things that can clue you into getting an MRI. On this slide, I just kind of wanted to highlight that in the theme of the spine being a dynamic organ, it does really matter on where on the growth curve these pediatric patients are. So, if you're in a period of rapid growth or growth spurt, that's usually the period when the deformity really progresses. So here are in the literature, two ways that clinicians are kind of used to evaluate where the patient is on that growth curve. So there's the Reiser stage of iliac ossification, where a stage 4 or 5 indicates complete ossification and more stability of bone growth, and also the presence of triradiate cartilage. So the purpose of all this is just to show that, an evaluation really does involve a holistic assessment of the patient. Um, this was a relatively novel finding. The rib vertebral angle difference has been shown to kind of indicate prognosis in pediatric deformity patients. So this is really just this angle X and angle Y in the figure. You find the apical vertebra, so that's the one furthest away from that CSVL, and you look at the angles formed by the ribs. And if you have less than a 20-degree angle in a young child, that actually does result in resolution of the scoliosis 85 to 90% of the time, whereas greater than 20 degrees typically results in progression. And the main reason I incorporated this is that there's a lot of research that's been going on in this field to kind of standardize and also prognosis of, progression of these patients. And they look at pretty much every possible angle that exists. Rib vertebral angle, the angle between the vertebra, this SVA, pelvic tilt, pelvic incidence. There's so many different types, and honestly, it's probably just going to grow with the advent of AI and radiomics. We're just going to keep developing these angles, and the question really will be which one of those are going to be actually important because you can draw a bunch of angles, but if it doesn't really change the management or natural history of this patient, then it's not going to be particularly relevant. So now that we've classified the patient, seen him in clinic, what's the next step? And in terms of management, there's really two options. It's either non-surgical, which comes down to bracing and casting, or surgical, which is can involve either non-fusion or fusion. Now, the caveat to this being is that if a patient has progression of their deformity, um, and or is having symptoms, the definitive treatment is going to be surgery. And even these non-surgical and or non-fusion options will almost inevitably result in fusion as long as their deformity continues to progress or is sizable to begin with. For bracing, the problem is that we don't have the greatest evidence. It's very hard to do a randomized control trial for this. And so the studies are uncontrolled and largely observational. And one of the largest issues is compliance. Um, Something that we have to consider is that a treatment is only as effective as the compliance of the patient, and there's a lot of social factors that go into bracing. Not to mention that no child really wants to be braced for long periods of time. So, you know, kids with scoliosis, especially with very large curves, already feel like they're going to be a little different from their peers, and if they have neurologic issues, bowel bladder incontinence. Having a brace on 24/7 when they attend school is, really messes with their psychosocial upbringing as well. So it's really difficult to manage a patient with only a brace. It largely only works as a stability. So it's trying to keep a patient's deformity at bay. It's not really for correction. And unfortunately, with no standardized indications or duration, recommendations can range from keeping a brace on for 8 to 23 hours. And, no child is really going to be enjoying that process. There's different brace types, but the real issue is that we're not sure if the risk of surgery is really altered with bracing. And the rates in the literature range all the way from 1 to 43%. So that it's not exactly a mainstay treatment option. But when would you brace? It's for patients who have a curve between 25 and 40 degrees that are still growing, or if their curve is less than 25 degrees and has about greater than 1 degree of progression a month. Um, the real question is that you want to brace patients who have skeletal immaturity. If they're skeletally mature, then their deformity is much less likely to progress. And so there's no real indication for a brace there. And of course, we have to evaluate the compliance and body habitus issues are also something to consider. In younger patients, there's a different set of criteria that I've listed here, but essentially it's the same issues. Is it really going to change their natural history or their need for surgery? And is the patient going to wear it? Other conditions, bracing for neuromuscular disease, it's really not that effective. But one thing that I did want to include is that sometimes it does help with their posture. So the bracing may not help with the deformity itself, but it can make, seating more comfortable, at least until they're able to get definitively fused. And it's the same for these other types of conditions where we can brace, keep them at bay up until they get a definitive fusion, usually around the ages of 10 to 12. The next non-surgical option is casting. And this is generally for infants for whom they're definitely not going to wear a brace. And so, especially for infants who have rapidly progressive curves. So, it's not really needed if the infant has a curve of less than 25 degrees or that rib vertebral angle difference that I brought up earlier is less than 20 degrees. Then the patient can just be serially monitored. But if the curve is larger than 25 or their RVAD looks greater than 20 and they're having progression, then these casts can be helpful. The treatment is really only until 18 months of age, and then we can start putting the infants in a brace. The casts are done under general anesthesia. The unfortunate aspect of this is that it's going to require a lot of work. Every 6 to 12 weeks, as the infant grows, the cast will need to be taken off and reapplied. And once again, this is really just this is just a delaying treatment for finalized correction. And so casting is not really used in any other conditions. The next, more invasive modality is going to be surgery without fusion. So this is where the main forces on the spine are just to try and keep the spine in an up and down direction, but it's to allow for growth. We talk a lot about, growth in spinal deformity, and it's a constant spectrum and a balance that you have to uphold. You don't want to completely um, you don't want to completely disrupt the growth plates and then the patient has stunted growth. But then at the same time, if you don't control the patient's growth, the deformity will likely grow as well. So there are surgical options where you can lengthen the rods after they've been placed, or you have multiple rods that you can lengthen. And this allows you to avoid fusion to allow the spine to continue to grow until the patient once again gets a definitive fusion. So um, this the if you haven't really worked with the spine from a surgical standpoint, fusion only really happens where we expose the spine, we decorticate the spine, and so the only places where these patients really fuse, if you're using these growing rods, is going to be at the ends, which is where the screws are placed, and we've had to expose the spine and decorticate it. Uh, you can brace after this growing to help promote some fusion at the ends of the construct, but all the vertebra in between don't get fused. And so I just wanted to show what these look like. As you can see, this is what the growing rods look like. And if you can see on that rod on the left, there's a telescopic portion. And every time you come in and redo this surgery, you can basically increase the length by increasing that telescopic portion at the end. So you're only fusing the top and the bottom where the screws are. Everything in the middle is not subjected to any fusion. Of course, in the surgical world, you like to do things only once and not have to go back in, and this surgery is the very opposite of that. So complications are going to be quite high. The main complications are going to be rod breakage or hook displacement, and that's because you could be spanning 11 levels of the vertebra, but only the top two and the bottom two are fused. That means that there's a lot of strain on these rods. Um, the fact that we have to keep going back to the OR multiple times means that there will be an increased risk of infection and wound breakdown. Um, the argument for the use of growing rods, though, is that um, if you treat with fusion, you can cause disruption of that spinal growth curve, which would be as problematic to the patient as the deformity itself. So, for example, if you were to fuse up front before the patient's completed growing, you could have a short trunk. The lungs would be hypoplastic because they don't have enough room to develop. And I'll get into what crankshaft phenomenon is in another slide, but that's basically a phenomenon where the anterior spine has intact growth end plates because we only operated on the posterior spine. And so the anterior part of the spine continues to grow and causes this deformity to happen because the posterior isn't growing anymore. So it's out of balance. Just wanted to include this. This is a cool thing that operation that had developed because of actually thoracic insufficiency syndrome to help improve respiratory function, but they found that simultaneously it did help patients' spinal deformity. It was just something that I thought was historically neat, but it has fallen out of favor, mainly because of issues like extraspinal ossifications and the need for serial lengthening and reoperations once again. And so, of course, the most definitive option, the one that you'll see on our OR board most often, is going to be fusion with instrumentation. And this is really dependent on where a surgeon trained and their own experience, whether they use hooks, wires, screws or rods, but the most of the time it's going to be using screws and rods in today's surgical world. These days, we have the ability to navigate. It's not used often in the pediatric world as much as it is in the adult world, but I just wanted to include these pictures if you haven't seen what putting screws in the spine look like from an OR standpoint. We quite literally are able to use these very futuristic looking instruments to place a screw exactly where we want in the spine. So this allows for less complications. Um, Compared to prior devices, screws really allow us to exert a lot of different forces on the spine and help it contort it the way that we would like the spine to grow. So this includes torsional forces, tilting, distraction, compression. So we have a lot of tools at our disposal now with the use of these screws and rods to kind of contort the spine. The success of this kind of surgery depends on the degree of fusion. And so that, of course, is what we're assessing on post-op films. And once again, the holy grail of pediatric or really any deformity surgery is to be able to fuse the least amount of levels and get the correction that we need. And that's where the Lenke system really shined. There's multiple approaches. You can go posteriorly or anteriorly. The anterior is more rare. Most fusion is going to be done posteriorly, but anteriorly, sometimes for a really large curve, we have to get into and release the anterior longitudinal ligament seen here. And this can also be used to purposely disrupt the growth plate. So I had mentioned the crankshaft phenomenon earlier, where the anterior end plate is still intact, while the posterior is fused and that disrupts the balance. If we put a vertebral cage in there or purposely get into the anterior end plates, we can disrupt it so that there's balance again. So um, sometimes this is a necessary surgery. And especially in myelomeningocele, a lot of times the posterior elements are completely absent or not formed or developed enough. And in that case, an anterior surgery might be necessary. Complications, these are really large surgeries and they can have a complication rate of up to even 25 to 35%. The main ones that are going to be the most common are going to be bleeding, neurologic injury, and positional complications intraoperatively. Postoperatively, the things to look out for and what patients will complain about in their post-op clinical visits are going to be persistent pain, infections, pulmonary complications, and several others that I'll get into in these later slides. So intra-op complications, bleeding is going to be the biggest one. So transfusions are quite common in these surgeries. These are large operations. The spine often is incredibly vascularized along with the muscles and tissues that surround it. So it's not uncommon. So one in every four patients to get a transfusion. Obviously, the risks increase if you have more levels, if you have a posterior versus an anterior approach. And we do the best we can to try and minimize this by giving local anesthesia. And also, there's studies that show controlled hypotension via anesthesia during the exposure is particularly helpful with blood loss. So this is always going to be a team sport. And discussing with anesthesia, having a plan pre-op is vital for these big kind of surgeries. Neurodeficit, thankfully, is not as common. It's less than 1% overall. However, it has really improved in the last couple of years, especially with intra-op monitoring. So now we monitor for motor pulses, SSCPs, and we work with anesthesia and our neuromonitoring team to really make sure that we're avoiding any cases of obvious screw misplacement that could cause a deficit. The good news is that about 90% of these patients recover. Unfortunately, it does take about 1 to 2 years to have complete recovery in most of these patients. And the main issue is going to be mechanical injury, either from screw placement or a hematoma that's formed. But once again, it is absolutely vital to follow these patients. If there is an issue that's uncovered, then the patient may need to go back to OR to have a second decompression or revision of those screws that are causing the issue. Positioning is also very important. Once the patient is draped, they're going to be there for about 5 or 6 hours, and it's our focus is now once again on proper instrumentation and exposure rather than their positioning. So it's very vital to get their positioning set up appropriately in conjunction with the anesthesia team before we start. One of the scariest complications is post-op vision loss. So it's important to properly pad the eyes. Luckily, that is also quite relatively rare. But the ones that are particularly difficult to assess in the post-op period and tease out, is this because of an instrumentation issue or is this because of a positioning issue, or is going to be the post-op peripheral nerve injury. So it's important to pad any bony prominences and make sure that the patients are in a neutral anatomic relaxed position because once again, they will be there for 4 to 6 hours on average. And the issues can come from direct pressure, stretch, ischemia, and it becomes quite difficult to determine is this because of a screw issue or is the patient having any compression of their spinal cord if they have any nerve injury post-op. So if you plan in advance, you can avoid a lot of these complications. Surgical site infections are always going to be a risk for these large incisions, and especially in patients who have other conditions that we have to be aware of. So, a lot of neuromuscular deformity patients are going to have bowel bladder issues, impaired mobility and sensation. They won't be able to, they're going to get these muscle sores from not moving as much. And all of these are going to increase the infection rate, especially a lot of our incisions are on the low back. And if the patients don't have proper bowel or bladder control, often need a diaper. If the incision is getting bathed by, these fecal matter, then that's really an infection risk that we have to be aware of. A lot of these patients also have things like a VP shunt. They're malnourished. And so, the protoplasm also really matters. The management for these kinds of things, you can try to do antibiotics, but definitive management is usually incision and drainage, especially if the incision is dehisced or there's some sort of drainage. There's a lot of efforts in the OR to remove. This is a metric that gets tracked to try and prevent these types of infections. So this goes from the prep to antibiotics to what types of dressings are being used. So this is something that hospitals around the country are constantly tracking and are trying to bring down. The point of this slide goes, and the next couple of slides are to kind of emphasize that once again, as neurosurgeons, this is really to remind myself as well. We get so bogged down on the deformity in the spine that we have to remember that, we're treating the patient as a whole. A lot of the surgeries we put activity restrictions. Some of our patients have pre-op existing hypercoagulopathic conditions, so we have to be aware of, thromboembolic events or PEs. The good news is that the risk is largely still less than 1% in, overall. And there was a study done by Jane et al. Of 22,000 patients where less than 0.04% of patients developed any of these complications. So post-op anticoagulation is still not recommended, but it is something to be aware of. Luckily, children in general, much healthier than the adult population, this is less of a risk. Similarly, there's a lot of possible pulmonary complications, pneumonia, edema, respiratory failure. Some of our patients remain intubated post-op, and so getting them extubated as quickly and safely as possible is definitely of vital importance. Um, and the other interesting thing to remember is that thoracic fusion, especially in a growing patient, can disrupt lung volumes and PFTs. So that's something to keep in mind that just because a fusion might be indicated earlier from a spinal standpoint, it can cause respiratory issues and prevent the lungs from fully developing down the road. This one was a real blast from the past. I remember hearing about this syndrome in med school and then promptly forgot about it over the last 3 years of residency. But It is important to keep in mind because this superior mesenteric artery syndrome is very similar to ileus. And so the pathology behind this is that the superior mesenteric artery forms this SMA aortic angle that comes out anterior to the duodenum. And especially in a spine lengthening procedure. So if you take a curve and you straighten it out, by definition, you are lengthening the spine. And the aorta and the surrounding spinal vasculature are very adherent to the spine. So if you lengthen this the aorta out and you cause this new tension that wasn't there before, that SMA angle can cause the duodenum to close off. And so, that'll present as vomiting, abdominal pain. It'll look very similar to ileus and also manage quite similarly with, decreased PO and then an NG decompression. But luckily, doesn't really require removal of spine instrumentation, but this is why it's very important that before leaving the hospital, we have to confirm that a patient is keeping food down. And honestly, this is why it's in general a good idea to keep patients to observe them for at least a couple days, make sure that this syndrome doesn't develop. And of course, mechanical complications. So, pseudarthrosis is the failure of bony fusion. And this is always the correction of the deformity is only going to be as good as the fusion that we're able to achieve. And if we don't achieve any fusion, then the deformity will continue to progress. So this is what we're monitoring for on post-op films. As you can see in this top right, there's screw lucency that's showing that these screws are not very well held in place and are constantly moving. The next deformity we look at is proximal junctional kyphosis. This is where there's an increased kyphotic angle higher than the construct. This almost always requires revision and extension of fusion. And once again, the incidence of this is quite high, up to 50%. So this is why these patients need long-term clinic follow-up to continue to make sure that their fusion construct hasn't changed and their deformity hasn't progressed. Crankshaft phenomenon, I kind of talked about it earlier. It's when there's imbalanced anterior growth of the end plate. And the way you can treat this is an anterior approach or an anterior fusion for definitive treatment. And of course, revision surgery is going to be the most common complication of scoliotic correction. So um, often, you try to go for the smaller correction, and sometimes the deformity still progresses or they develop what, like I mentioned, proximal junctional kyphosis, and you'll have to have a more invasive or maximally invasive surgery. This is just showing, the audience that may not have been involved in a spinal surgery, that depending on how much bone we take out from posterior approach, can show us how much correction we get. So if you only take out the pedicles or the spinous process, you can get about 10 to 15 degrees of correction. But if you start to go further into the anterior vertebral body, take out more wedges, the level of correction can get larger and larger until you're doing a complete vertebral column resection and you're getting up to 30 degrees of lordosis. So anyway, just wanted to end on that note. I just wanted to say that these were, once again, the main objectives. The spine is dynamic. Um, Even today, a surgeon down the street and may give a completely different operative plan. And I personally hope that with the research that I aim to conduct during residency and afterwards, that there's a more of a standardized approach to spine. And the last thing, once again, as a reminder for myself, is that, we are doctors first and foremost, and not just surgeons. And we have to make sure that we incorporate the entire team, whether it's anesthesia, PCP, or other specialists, including the intraop team, with the intraoperative monitoring, the scrub tech. Everyone has to be on the same page before we undergo any type of correction, and this will ultimately serve to benefit the patient the best. So with that, thank you for attending Grand Rounds and bearing with me today, and I'm happy to take any questions.
So that was a really great talk. I was just wondering if you have any knowledge about like the Unid platform where you have these like personally or personalized created rods that you can then fit the spine to using a patient database by these rep like these companies like Medtronic. Just curious what you think about that and how this is going to change the future of spine deformity.
Yeah, I have seen it in the adult world, and I honestly was kind of surprised by how good that pre-bent spinal rod was. I know the way they do it is that so you submit these global spine X-rays, and then you actually, at least the one I've seen, you can even tell them what correction you're planning on doing, and they are able to estimate how many degrees of lordosis each, for example, intervention that you will have, and then they model the curve based on that. And I remember the one I saw, it was actually really well done. We pretty much had to make no adjustments. I think it's tougher in the pediatric spinal deformity world because a lot of uh, a lot of decisions are made intra-op. I think in an adult world where the spine is already formed and there's not really as much growth, or at least the growth rate is much slower, it makes more sense. I hope that these, I personally am interested in artificial intelligence, and I know that these databases that uh, are used to kind of basically tell us what the rod will look like or what kind of surgery we're going to do, they're starting to form, but I know that at least for true big data work, you're going to need something on the order of not just thousands, but like tens of thousands before we get actual good data from it that we can apply to a large variety of patients. I think it's a good step. And like I said, the one that I've seen, they did a great job with the pre-bent rod. Um, but I think there's still more work to be done because we just don't have the number of patients yet.
Hey, Sid, can you hear me?
Yes, sir.
Yeah, thank you, Sid. That was great. That really felt like it educated me very nicely on, the categorization approach to spinal deformity. For the audience, since we have a lot of neurologists and non-spine neurosurgeons on, would you mind just kind of briefly addressing how do you think about neurosurgical pathology in the setting of deformity? So, syringomyelia or tethered cord, you talked a little bit about the high incidence and the syndromes. But when you see a patient with a spinal deformity and syringomyelia or spinal deformity and tethered cord, how do you approach that? How do you think about what surgery to do when?
Yeah, I think at least the ones that I've seen during my rotation here, I think it depends on which pathology is going to be um, basically most helpful. Treatment of which pathology is going to be most helpful for the patient, slash which one is going to kind of impede the future surgery. So if you're dealing with a patient with a tethered cord and they have a spinal deformity, then the first step, I think, is to understand what the patient's signs and symptoms are and which pathology you think that's coming from. And second of all, I think just if I were to clinically think about the patient, if you already have a tethered cord and you aim to fix their deformity, let's say with a fusion, I imagine that would cause increased lengthening of the spine because now you're straightening out the spine essentially. And if the tethered cord was already an issue, it would probably become a greater issue um, after lengthening. So in that case, I think most providers would uh, try and see if the symptoms are coming primarily from the tethered cord itself, and if just treatment of that alone would help treat the patient at that time. I think fundamentally, most surgeons try to do the least amount of surgery possible for maximal benefit for the patient, and if you can get away with just a tethered cord or like a detethering rather than having to do a whole fusion. And once again, with the fact that there's multiple forces constantly on the spine that are contributing to the deformity, it's very possible that the tethered cord itself is secondarily contributing to that deformity. So I think I would probably try and treat um, the tethered cord or the syringomyelia before tackling a deformity, but it depends on a patient by patient basis.
Thanks, Sid. Beautiful job.
Thank you.